Hello, everyone, and welcome to our seminar today. And thank you so much for joining us for our seminar on the impact of fascia on health. My name is Mahtab Jafari, and I'm a professor of pharmaceutical sciences and the director of the UCI Center for Health and Sciences at UCI. One of the major goals of our center is to educate and inspire our communities about evidence-based modalities that they can use to improve their health span and to foster healthy aging. Today's panel discussion is co-presented with the UCI Center for Integrative Movement Science, and it is now my pleasure to introduce my colleague, Dr. Monica Daly, who is the director of this center. Dr. Daly is an associate professor in the Department of Ecology and Evolutionary Biology at the School of Biological Sciences. The focus of her current research is on the interface of biomechanics, neuromuscular physiology, and neuroscience to understand how we can achieve integrated function for stable and agile movement. She received her PhD from Harvard University in organismic and evolutionary biology and completed a postdoc training in kinesiology at University of Michigan in the Human Neuromechanics Lab. And this is a lab that focuses on human movement and rehabilitation. Monica.
Thank you for that introduction. I'm Dr. Monica Daly, and I'm the director for the new Center for Integrative Movement Sciences in the School of Biological Sciences at UC Irvine. And our mission is to promote innovation and discovery in all fields associated with movement and to promote awareness of the importance of exercise and mobility for human health and well-being throughout life. And we're a consortium of so far 24 faculty and growing across the UCI campus, plus 22 external affiliates around the country. And this is a group of physiologists, biomechanists, neuroscientists, cardiovascular biologists, pulmonary scientists, biomedical engineers, and rehabilitation scientists, among others. I just wanted to tell you about a couple of upcoming events that we are sponsoring. We're proud to sponsor this webinar on the role of fascia in human health. We were also sponsoring a symposium in December, an interdisciplinary symposium exploring embodiology, which will be exploring indigenous West African knowledge in optimizing human performance, which will be led by Dr. Amma Ray in the Claire Trevor School of Arts and is co-sponsored by the Center for Neurobiology of Learning and Memory. And we also have some new and exciting collaborative projects starting in the new Human Performance Lab in SIMS, investigating the neuromuscular control of compliance in human movement and using exoskeletons for walking rehabilitation. And we're also have some collaborative projects investigating how experience informs learning and injury risk mitigation in dance movement in collaboration with the Department of Dance. So if you're interested in some of SIM's events and research, or if you're interested in becoming involved or donating, please go to our webpage. We have a webpage at sims.uci.edu. That's CIMS.uci.edu. Thank you.
Thank you so much, Dr. Daly, and thank you so much for collaborating and co-presenting our program today. Before we move to our panel discussion and our speakers, I would also like to acknowledge the gift that our center, a generous gift that our center received from the K Family Foundation. And it is really because of this gift that we have been able to organize such seminars as the one today. Many of our audience members also participated in the seminar from last month, which was on nature therapy and the impact of nature therapy on health. And our goal is to, because as you can see, we are recording the seminar today. So our goal is to eventually create an archive of all these recorded seminars and post them on the center website. And going back to our program, we are going to have two panelists for our presentations today, and we are going to have a discussion at the end. So please make sure that you type your questions in the chat box, and we try to get to as many questions as we possibly can. So now it's my pleasure to introduce our first speaker, Dr. Helene Langevin. Dr. Langevin was sworn as the director of the National Center for Complementary and Integrative Health in 2018. Before joining the National Institute of Health, Dr. Langevin was the director of the Osher Center for Integrative Medicine in Boston, jointly based at Brigham and Women's Hospital and Harvard Medical School, and a professor in residence of medicine at Harvard Medical School. As the principal investigator of several NIH-funded studies, Dr. Langevin has centered her research around the role of connective tissue in chronic musculoskeletal pain and the mechanism of acupuncture, manual and movement-based therapies. Her more recent work has focused on the therapeutic effects of stretching on inflammation. Dr. Langevin received her medical degree from McGill University in Montreal, Canada. She completed a postdoc research fellowship in neurochemistry in the Medical Research Council Neurochemical Pharmacology Unit at the University of Cambridge in England, and a residency in internal medicine and postdoctoral fellowship in endocrinology and metabolism at the Johns Hopkins Hospital in Baltimore. Helen.
Well, thank you so much. And it's really a pleasure to be part of this panel. I never turned down an opportunity to talk about fascia because I've been interested in fascia, connective tissue for my entire career. I'm going to share my screen. I'm going to see here. Share screen. Voila. And can you all see my slide? Yeah, good. So the title of my presentation, as is the title of the discussion that will follow, is the role of fascia in health. And so two very interesting topics. So I'm going to be just kind of high level looking at the following questions. First of all, what is fascia? And then the second question, what is health? And are the two related? And these are not obvious. The answers to these questions are not totally obvious because these are two areas, both fascia and health, that have been surprisingly studied quite very little compared to other areas of medicine. So when we talk about fascia, what exactly are we talking about? And so here I'm kind of presenting this, and there are various different ways to think about this, but I think it's very helpful to think of fascia as part of a multi-scale continuous body-wide network that we talk about using different names depending on the scale that we are looking at. So when we think about it at a very microscopic scale, sort of at a cellular level, we talk about the extracellular matrix, right? And then when we zoom out a little bit more, and we look at tissues, we sometimes use the term interstitium, right, to talk about the connective tissue that is sort of woven in between the other tissues of the body. And then when we talk about the organ level, or say here we have a muscle, but the same thing, it could be a heart or a liver. We talk about the connective tissue, or sometimes we use the word stroma to describe the connective tissue pertaining to a specific organ. And then when we zoom all the way out to the whole body, then we talk about fascia. And what are fascia? They're these big sort of anatomical sort of sheets of connective tissue that can bear substantial loads. And I'm going to also talk about how the fascia, even though the fascia they're set themselves, the sheets of they're quite tightly woven connective tissues, they're organized in layers. And this is very, very important to understand the biomechanics of the body. So in the body, there's various different kinds of forces that are exerted, either externally applied force or forces generated from within, for example, from muscles. And these forces can be either tensional forces when you pull things apart, or compressional forces when you push things together, or what we call shear forces or shear stress when two parts of a body are moving in opposite directions from each other. And what I want to illustrate here in this movie is, this is the thoracolumbar fascia in a human. This is an ultrasound movie. And the white lines that you see here in the middle, these are different layers of fascia. And I hope you can appreciate how they are moving in relationship to each other. And in between these layers, there are these kind of, on ultrasound, they're echolucent, sort of darker bands that allow what we call the shear plane or motion or shear strain between these layers. And this is a very important part of mobility. And a lot of mobility in the body is not due to so much to the fascia themselves stretching, but more they're moving in shear. And it's because of the ability of this loose connective tissue in between the fascial planes to allow this movement. And very often what happens in an injury is, I'll talk about that a bit later, these layers actually get stuck and don't move quite as much. So, okay, so we talked a little bit about fascia. What about health now? So I've written here 3 sort of attributes of health. By no means this is meant to be an exhaustive list. These are just 3 examples of qualities of health that I thought would be interesting to discuss in the context of the role of fascia in health. So one possible characteristic of health is the ability to sustain a healthy physiological function, right, of these various organ systems that we have in our body. Another characteristic would be to be able to produce physical work, right? This is very important. For example, in more sort of primitive societies, if you were not able to produce physical work to, say, gather food or create shelter for yourself or defend against predators, you would probably suffer and perhaps wouldn't survive. Now, in our more modern societies where we are not quite so physically active, we know that if we don't move enough, we become unwell. And therefore, people go to gyms, right, to produce physical work that is mainly intended to stay healthy and strong. And then another characteristic of health is the ability to recover or adapt following injuries or insults or illnesses or viruses or whatever you have. And so these 3 characteristics: sustain physiological function, produce physical work, and be resilient or be able to recover are, I think, 3 characteristics of health that I want to discuss here. So first look at the first one: sustain physiological function. What would connective, and I'm going to use the word connective tissue here in this discussion rather than fascia, and I hope you understand based on that continuing picture that I showed earlier that it really is, I prefer using the word connective tissue, but some people use the word fascia as a synonym for connective tissue, and that's okay most of the time. So what about the role of connective tissue in sustaining physiological function? Well, because connective tissue is a network, right? It really connects all the parts of the body with each other. And what it does is it transmits mechanical forces by which one system of the body can influence another. Now, we understand a lot about physiological functions, one system at a time. What we're not so good at is understanding how the various systems connect with each other. And I think that to understand better how connective tissue can mediate some of these connections, I think is going to be very important to better understand how the body functions as a whole. So here, I'm just going to give you an example, right? And there are many such examples, but I'm talking about the gastroesophageal junction here. This is the junction between the esophagus here and the stomach. And when we think about it in sort of gastroenterology, we usually view this from the inside, right? This is an endoscopy at the top left here, where you put a tube down the esophagus and you see the inside of the esophagus. And we don't often think about this, or what does this look like from the outside? But if you stop and think about it in the pictures that are shown on the right here, there's a lot going on outside of this esophagus. There's the diaphragm, right, that arrives here and connects with the esophagus right at the junction, by the way, and the perimuscular fascia here of the diaphragm connects with the fascia that invests the stomach down here and the esophagus up here. So when you breathe, right, what happens is your diaphragm is moving up and down. And if you were to ask somebody who does, yoga or something, is it possible that how you breathe influences your digestion? I think a lot of people would probably say yes, but we don't really know much about it because there's very little research on this. So understanding the effects of how the fascia and the role of the connective tissue in connecting these various different organ systems, the respiratory system, the digestive system, and the musculoskeletal system. This is an area that's very important. The second thing I'm going to talk about is the connective tissue as a substrate for mechanical forces. What do I mean by that? Well, we know that in the body, the mechanical forces are endogenously produced by muscles. And we used to think, right, that when a muscle contracts, it's pulling on the tendon, which then pulls on the joint. And that's true. But recently, it's been shown that a substantial proportion, up to 30% estimated, of the forces that a muscle exerts when it contracts is on the perimuscular fascia and pulls the fascia that is right next to it and essentially kind of produces a mechanical force within the connective tissue. And we know that connective tissue reorganizes, right, in response to mechanical forces. We know that this can happen even extracellularly in for example, a collagen gel, a dish in a collagen gelled in a dish will reorganize itself if a mechanical force is applied to it. And in the body, so this happens, but in addition, there are fibroblasts within the connective tissue, which further promote the reorganization and reorientation of the collagen matrix in response to the forces. And what happens in a case like that is as the connective tissue is getting reorganized, this changes the shape and the mechanical properties of the connective tissue, such as stiffness and viscosity, which then affects the environment around the muscle. We know that if a muscle is either too short or too long, this impairs the ability of the muscle to function. So this sort of length tension curve will then affect the muscle contraction pattern. So you can see that there's kind of a feedback loop going on here. Now, the third aspect that I want to talk about is the ability to recover and adapt. And this is related to this kind of mechanical transduction mechanisms that I've talked about before, in terms of the ability to repair and remodel itself. So what about repair? Well, the simplest thing that we understand about repair is healing a wound, right? You cut yourself, the connective tissue comes in, and fibroblasts start secreting various different cytokines, for example. They increase their production of collagen, they reorganize the wound, and finally they close the wound, right? Actively contract and close the wound. But here I've shown an example of a wound that we don't often think about. Instead of a cut that would be transverse to the body, here we imagine that you have now an injury that is parallel, right? Or a shear plane injury here. So you see the two layers of connective tissue here in blue. After an injury, this type of injury, you can see that the layers have fused together and gotten thicker. This is what we call a shear plane motion sort of reduction. These layers are no longer sliding past one another, and this can result in a decrease in the range of movement. The other way that repair can actually manifest itself, but in a positive way this time, is through remodeling in response to change in behavior patterns. Imagine that you are always sitting down at a computer like this, for example, and your muscle contraction pattern kind of becomes more and more sort of limited, and you don't stretch, and gradually your muscles and your connective tissue will start remodeling in this kind of abnormal or sort of stooped posture. And pretty soon when you try to straighten, you can't, right? Because the connective tissue has sort of remodeled. And so this feedback mechanisms that I talked about in terms of the length tension curve and the remodeling of the connective tissue can have a bigger feedback in terms of a feedback involving the nervous system, where there are mechanoreceptors and nociceptors within connective tissue that can signal to the brain about the sensation of stiffness. Like, I don't feel good. My muscle won't move like I want it to move. Now, if in response to this feedback or stiffness sensation, one starts to do yoga, for example, and start to stretch, you can actually change the muscle contraction pattern and the connective tissue remodeling in order to repair essentially this posture. And so that's the good news, is that connective tissue can be plastic. So so I'm just going to summarize here in terms of the 4 things that I've talked about. So multi-scale network of fascia or connective tissue, whatever you call it, that has both strength and mobility and can transmit mechanical forces and then create this kind of plastic remodeling in response to the movements that we do or don't do every day. So I'm going to stop here and look forward to the discussion.
Thank you so much, Dr. Langevin. When you were talking, I definitely wrote down my questions. So hopefully I will get to ask you the question, but I would like to move on to our next speaker. And I would like to introduce Dr. Christopher DePrato, who is a researcher and physical therapist at the, hi Christopher, who is a researcher and physical therapist at the University of California, San Francisco and UC Berkeley. And he also teaches in the orthopedic residency for the UCSF School of Medicine. He serves also as a consultant for a variety of organizations in the NBA, MLB, and NFL, and Team USA. His research has looked at the importance of fascial health as blend of movement, loading, and biomechanics paired with manual therapy. His current work focuses on the effects of instrument-assisted tools, namely negative pressure cupping, on soft tissue structures, including fascial mechanisms and their relevance to musculoskeletal pain and sports medicine. Dr. DePrato received his doctorate in physical therapy from Temple University. He is board certified in sports through the American Physical Therapy Association. He's also a performance enhancement specialist trained by the National Academy of Sports Medicine. Christopher.
Thank you for having me. I'm very humbly excited to be here. Again, Dr. Langevin has produced so much research that has been inspirational to this field. And so I'm really happy to be here presenting alongside. So thank you for hosting. I'm going to share my screen here and it's a great kind of segue to pick up where she left off and talk a little bit more about the musculoskeletal effects of those. And specifically my area of focus is physical therapy. So musculoskeletal systems, PT stands for pain and torture. And so I'm going to show you guys some of the things that we do when that behavioral model does not go back to someone wanting to move the way she just presented, and how we can jumpstart the system to hopefully change some of that and get people back on that moving train again. So I'll skip some of the disclosure things, except for I do own a continuing education company where we go around the nation and now internationally to present some of this fascial work, as well as the use of negative pressure, which again has been seen in the world stage of the Olympics with the Michael Phelps effect of 2016, with the Rio Olympics with cupping all over. And so that was part of our work that we did with Team USA in 2015, 2016. And so we'll talk more about that and how that fits into the whole fascial system talk that we're doing. But basically, I got really interested in the area of fascia working with athletes. And so I started going around and I worked with California, Berkeley, and I started there in their sports medicine group, and then started working with some different NFL teams, San Francisco Giants, and presenting different manual therapies on how they have effects on fascia and the connective tissue system that we're talking about. So I've gone around to many different groups now in the last 10 years or so. Very humbled again by being able to have the opportunity to work with these different groups. And you guys can see there's many different athletes out there that really benefit from this, as well as weekend warriors and general public that actually doesn't want to move as much as they should, as Helene had just kind of presented. So lots of big names. And when you get a big name with a mark on them, people ask questions, right? And you start to see, and it gives a bigger stage to this big question of why is fascia so underappreciated in medicine? And I think that's one of the most important takeaways from this talk today, is understanding how fascia fits in the grand scope of medicine in general. So the way I want to frame it, and simply put, is understanding how she, Dr. Langevin, really eloquently presented that these systems are so interconnected, yet we do not understand the forces of one upon another. And I think some of the ways we can start to frame that, we are very visual learners most of the time, and to understand the connection pieces, I want to just show you guys some of these systems and how we can think of fascia as that weave that interplays between them and has that interplay to allow movement to transmit forces from one system to the other to another. So we really kind of understand now that there's force production and fascial slings going throughout the body. And the way the body produces these myofascial transmissions affects maybe your shoulder from something that has happened to your hip. So you can think of a quarterback throwing a ball, and the way their opposite hip can actually impair their ability to throw a ball. So we've come up with these different ideas. And just remember that we are pattern recognizing animals, and the way we digest information is in patterns. So we've created slings to understand the way these fascial force transmissions happen throughout the body from top to bottom, right to left, and from superior to inferior. But what I want to draw your attention to is the way some of these slings start to look a lot like some of the other systems of the body, specifically the nervous system, right? So we understand that there are lots of nerve tracts throughout the body, but if you start thinking about the way these fascial slings look, and then you start matching them, or maybe even laying them on top of the fascial slings from the nervous system, you can see when we lay them on top of each other, they start to get very, very similar in the way they move and the way they interact. So some of the other systems I think we don't appreciate as much as something like the nervous system or something like the musculoskeletal system and the slings that are kind of present in that fascia or the connective tissue elements is something like the lymphatic system. So the lymph system is also very similar in its presentation, and the tracts that are laid down throughout the body really match very well from the nervous system to the lymphatic system. So we can see if we lay and superimpose them one upon another, they are kind of mirror images of each other. And then if you look at the lymphatic system and pair that and lay it on top of, say, the circulatory system. And so these tracts all look very similar, and you start to see patterns. And as pattern recognizing animals, we can see how these different systems all kind of work together and have an easy transmission of forces from one to the other. What I think is also underappreciated in allopathic medicine is the ability for the mind and body to connect all these pieces together. And as Monica had said earlier, the brain only tells the body what to do, and the rest of it is up to forces and the myofascial force transmission that happens throughout the body. And I think the area that's really understood this better and recognized this better is the area of Eastern medicine. And if I look at this body diagram of meridians, well, that really looks a lot like the circulatory system. It really looks a lot like the nervous system. It really looks a lot like the lymphatic system. So I think something that has really grown in my mind is the understanding of the mind-body connection and these intersystem relationships, and that idea that the mind and the body aren't just connected emotionally, but also physically with the different systems and the way the connective tissue system lays down between these. So my area of focus, again, is going to be musculoskeletal system, because I want people to get stronger and move more and move better. So I think if you look at a big umbrella concept of how this system can affect other systems, say something like your diaphragm moving more efficiently to affect your gastrointestinal efficiency, you can think of like, how are you moving? Is it enough? Do you move in enough planes of motion, like in terms of variation? Or that variation can also look at velocity, right? Do you just move slowly like a sloth all the time, or do you vary it and you move faster sometimes and slower at other times? And then when you move, do you do that with load? Meaning, do you carry things? Do you have to push things? Do you have to pull things? And these loading factors really play a big role in telling the fascial system or the connective tissue system to lay down more of this strength of tracks, right? And so when you have an injury, sometimes it restricts some of that gliding, like we had presented earlier, and you need to teach the nervous system telling the fascial system to start to lay down better tracks or more parallelly organized tracks so that things can move a little bit more with the shear forces that happen. We'll talk about that more. And so when you do have an injury or you don't move enough, sometimes things start to feel stiffer, or you just get older and we also feel stiffer over time. And then what doesn't move well over time has maybe an injury as its background or lack of movement. But you have to ask, is it a hardware system or a software system? And the hardware is all the physical things that are in your body. Basically, we are a big meat bag, right? We are a bag of meat and connective tissue all kind of moving together. So that's hardware, that's physical stuff, versus a software issue, right? In the world of computers, we can think of it as hardware or software, and the software is your nervous system. It's the central nervous system telling you how to move it and what that looks like. And so it's my job as a physical therapist to look at the way people are moving and figure out what's not doing its job. Where is that weak link in the chain? Is it force transmission, or is it just the way they move, or is it the velocity that they move at, or are they not moving in other planes of motion and only in one plane of motion? Say like a runner only moves forward. They only stay in that sagittal plane. And I wanted to teach them to move in the coronal plane or the transverse plane more often. And then what is possible for each person's body? And what does that look like? And generally, if we move more in more planes with more velocities, with more loads, we're going to increase the body's resiliency and longevity. And in an aging population where the potential for life may be 110 years of age or 120 years of age by the time, hopefully I'm at the end of my life, I want to have a body that still works for me. Okay, so those are important things to think of. And fascia, I think, is the crux for how we can tap into these systems and the interdependence of one another. So just kind of brushing back up onto the anatomy, I think we already saw a few slides on this, so I'll go really fast. But as pattern recognizing animals, we learned in anatomy, going through medical school or going through PT school or whatever other ancillary health system you went through, we learned the musculoskeletal anatomy specifically as origin to insertion, right? The bicep goes and moves the elbow, and it's a very kind of robotic look at the way the body moves. And when we think about the way fascia connects everything else, instead of just thinking tendon and muscle, we can think of connective tissue linking all the different systems together along with that musculoskeletal system. And that's really the way the body moves in general. So if we think about this science fiction analogy of the Terminator, we can think about the newer Terminator as really this interdependent model of all the different systems working together cohesively, synergistically. And it's not that old school Terminator that was Arnold Schwarzenegger back in the 1980s, right? So that's really the hard part of understanding and analyzing and researching this system, is that how do you analyze a bag of fluid that looks like that, right? That bioflow of a robotic kind of gel all moving together all the time. And that's the challenge of, I think, research. But if we use these analogies to understand what happens to you when you do age or when you do have an injury, is this picture on the left really shows you hopefully the space that we have for these different sheets that we had presented earlier. There's lots of space for gliding and sliding. And so if you think of this blue space as all the fluid matrix that allows for smooth glide and slide of these white circles are your collagen fibers, say. And there's lots of space when you're young and you're active and you're moving lots. And then what happens is, well, we age and we have trauma and we have repetitive stress that happens to our body. And we lose a lot of space for that glide and slide. And now there's more of that stuff that gets stickier and doesn't glide quite as well as it should. So that's just a nice analogy and a nice picture for you to think about. Why do I have to like stretch for 5 minutes every morning now that I'm 40 that I don't have, or that I didn't have to do when I was 20? Because now there's less space for me to glide and slide the way I was meant to. And so what we do in physical therapy is we try to get people to move more, and we have to get the energy in the system to move and agitate a little bit to get these things to slide and glide. So if I think about George here trying to get the ketchup out of the bottle, that ketchup in the bottle doesn't just flow naturally. It's maybe an aging body. And I need to get them on a bike before going for a run because they need to warm up the joints, or I need to stretch more. I need to have a little bit more warm up time so I can do the things I want to do. And this process is called thixotropy. So basically your body has some thickness over time. And that thickness, if you introduce energy into it, whether it's a tool or whether it's moving more or just active range of motion, you're going to decrease the viscosity of some of those tissues. So hopefully you can go from a less blue state of that previous picture to a more blue state where things have space to slide and glide. So what do those movements look like? Well, often they're paired with multiple muscle groups in these things called slings, right? So we can think of when you have to do something like a pull-up, it's not just your biceps pulling you up, but your biceps with your lats, and your lats have to use your abs to control the trunk so you don't arch your back. And then your abs have to connect down to the pelvis so you have good pelvic floor control. And all of that you have to do while you breathe so your diaphragm is going up and down. And these are all interrelated and interlinked with these things called slings, right? Now, the hard part about slings, and this is a great model that was created in around 2000 by Thomas Myers, is that it's limited because it's still a pattern of like this one thing that we think of in this one plane. Unfortunately, when injury happens, they can happen at all kinds of different parts of the body, right? So these spiral slings that are very popular in understanding the way we move in the transverse plane, sometimes you have an injury at your shoulder, at your pec, and that's going to affect things through the other side of your body into your opposite hip. But sometimes that injury might be in your lat instead, or it might be in your pelvis. So these slings can start from one place, but really spread to other parts of your body. And that's why maybe your right shoulder injury from 6 months ago is now leading to a left hip restriction. And those things really kind of transmit loads and repair differently when you have an injury in terms of that thickness that we saw on a previous slide. It gets stickier, it gets more cohesive, and you can't slide and glide the way you're meant to. Okay, so what things can affect that? Well, it's not just injuries, it's not just traumas, it's not just aging, but these other things like temperature, like hydration, like using different planes of movement, right? Like trauma, even stress, and all the different types of stresses that are out in the body or in the world can have an effect on these fascial systems, okay? So there's lots of papers looking at it, and this is an early stage of research, understanding how each of these different forces have an effect on the fascial system itself. And then my job is to figure out what to do about it. I have a patient that comes in, or an athlete that can't do what they want to do. I have to figure out what it is that they need. Most of the time, for the general public, it's that they need to move more, right? We are sitting at the computer way too much. We are in postures we weren't meant to be for many hours at a time. We don't move in all three planes of motion anymore. So one of those things that we need to do is just think about moving more in general. But then if you're only moving in one plane, say you're a runner and you only move forwards, well, over time, that can also be problematic because you're not challenging the other interplay of the other motions in terms of rotation or side to side bending. And so the big thing is to figure out when someone is a runner and they're like, I'm being good with exercise, I'm trying to move more. It's like, why are they having a thickening in that one area of their body that may not allow normal slide and glide of the fascia? And that's where my study comes in terms of the understanding of how a manual therapy tool like suction cups can change some of the spacing and some of the ability for that slide and glide to happen. So say you come in and you have a knee pain, a patellofemoral pain, and you can't move as well through your knee as you want to, and you can't run as long as you want to, and you're having irritability with that. So what we do is we look at what doesn't move well, and then what does move too much, and we try to stabilize the things that move too much and we get things to mobilize that don't move well. Right? And there's a big difference between flexibility and mobility. Flexibility is just like the ability to go through a range of motion, but mobility is the ability to go through a range of motion with muscle control, or more specifically, fascial control, right? So if I put cups on someone, that's nice, but if I put cups on someone and then I start to move them, it starts to be a very different thing than traditional cupping. And we saw that in 2016, a lot of marks and a lot of people thought they were doing traditional Chinese medicine when really what we were working with Team USA on is doing things like this, where you have a cup on and you're moving throughout a range of motion to be able to see how those effects have on their transverse plane instead of just their sagittal plane. So those types of things are very fascinating. So we worked with Team USA, and again, the big Michael Phelps effect that happened that year brought a big stage to the world of fascia. But you can see something like Michael Phelps back here looks very different than when the Chinese medicine swim team had their traditional cupping done, where it's much more focused on different meridians instead of specific parts. Michael Phelps had shoulder things that he wanted to reach better, and so it's specific to his shoulder. As compared to something like a traditional Chinese medicine approach, it's usually not with movement, it's more of a passive mobility, but it's geared towards allowing slide and glide in a different part of the body to affect maybe the nervous system itself. And we'll talk more about that maybe later in the question and answers section. But basically, we're looking at MRI study to try to see what is happening to these spaces on something like an IT band syndrome. Someone wants to run and they're getting pain on the side of their knee. And what we think is happening is there's less of that space to slide and glide. It's stickier. It got inflamed at some point and it created less space. So we started looking at this in 2015. And this is a study we did in 2018, looking at the MRI of IT band syndrome in runners. And so we took 8 runners and we looked at it to see if a cup could pull away the IT band from the femur. So this is the first time an MRI was taken of a cup on the body. And you guys can see here, this is the IT band in black, okay, with a cup on the IT band, pulling it away from the femur. And so what we're really interested in is, does that create space, and does that space change and last more than just the initial 24 hours of an inflammatory response to a manual medicine like this? And so what we found is that space does change, and we can get a significant change in the amount of space between the femur and the IT band, which is here in black again on this T1 weighted image. So we're really interested in space and how long that space can be changed for. And that's the area of research that really hasn't been done very much at all yet. So we're doing that with different parts of the body. Right now, we're looking at the space for the back, right? So this is the lumbar spine. I have somebody here in a picture side lying, and I look at different types of cups as well, silicone versus plastic, and we're trying to see what pressures affect which layers. So I really am interested in that thoracolumbar fascia, how thick it is, and then how that affects the multifidus, which is the muscle under there, and how much atrophy there is in someone that has low back pain. And when we can move things better, maybe that thickening doesn't have to be so sticky, and it helps resolve some of their back pain that they're having. So these are some of the things that we're just starting to scratch the surface of. I think one of the big things with fascia is there's more questions than there are answers, unfortunately. And it's an area that we just started understanding more of in the last 10 or 15 years. So these are things that I think are really exciting in the field of musculoskeletal research. And especially in sports medicine, we want to understand how this affects not just their pain levels, but their ability to have performance, and in terms of like their ability to do their sports and things like that. So that's just a quick presentation on what I've been doing. Thank you guys for tuning into this. I'm sure you're gonna have lots more questions. Some of my information's here to find out more. So thank you.
Thank you so much, Dr. De Prato, for this wonderful presentation. And thank you again, Dr. Langevin, for your amazing presentations. So we are moving to the question and answers and the discussion of our program. But before we, and I already have a few questions from the audience, but before we get into the QA, I heard both of you talking about the importance of fascia as a system. And I also learned from Dr. Langevin's most recent review paper that was published a few months ago, titled Fascia, Mobility, Proprioception, and Myofascial Pain. And in this article, you almost have a call. Dr. Langevin is asking for more studies and more education when it comes to fascia. So the question that I have for all of you is that why do you think this is a good time to start doing that, teaching fascia to our healthcare providers, students, and medical education, so that our students become more aware of this important system? And maybe this is a rhetoric question, but I still like to ask it.
Oh, should I take a stab at that? The answer is yes.
Mm-hmm.
You know, it's so remarkable how little attention there is to fascia and connective tissue in medical education. I think if you're lucky enough to be educated as a physical therapist, you probably know more about fascia, but still, I would guess that there's still a lot of room for improvement in the education of physical therapists even, and Dr. De Prato can tell us about what he thinks, but I just think it's a big blind spot that we have, that we just have not had the knowledge base, the research base until recently. And in our discussion prior to this, the talks we were talking about the Fascia Research Society that has been really important in raising the awareness of the importance of fascia. And the first meeting, I think, was, I believe, in 2007. And since then, there's just been a real upswing, I would say, in how much attention people are paying. So this is good news. We're going in the right direction.
Thank you.
I would say even in physical therapy education, 15 years ago, when I went through school, you didn't hear about more than 5 minutes on the connective tissue system. It was 5 minutes, and all that went through was epidermis, dermis, subcutaneous fat, and let's move on to muscle, organ insertion, nervous innervation, and blood supply.
Yeah.
And then you spent 4 months on that, which is a lot of information. I think that's the challenge, is there's so much information already, and information is exponentially growing. So where do we fit it in a medical education? I think that's the number one question. And do we prioritize it? And I know we don't prioritize it enough, and we need more research to draw the attention to say this is a big deal. Just like the influence of the diaphragm on digestion, something else so simple like
yeah, there's another important thing here too, that the cadavers that students dissect are embalmed, and therefore the connective tissue is all kind of deteriorated. And when you dissect an embalmed cadaver, you don't even see the fascial planes. It was only recently that some anatomists, a lot of them in the school in Italy, the Luigi Stecco and Carla and Antonio Stecco, they really demonstrated that when you take a fresh cadaver and you dissect it using your hands instead of sharp tools, you can isolate these planes. And that was groundbreaking. After, when people started realizing that, they started really understanding the anatomy of the fascia much, much better. So part of that was just the methods that we were using to study anatomy before were just not there.
Yeah, and I also would add that like anti-manual therapy antagonists point to like, you know, a beefsteak and say, well, how are you going to feel the fascia? You know, they take a big lump of, you know, ribeye or filet mignon, and they have, you know, these ideas that, you know, you can't palpate, you can't move these things, but that's a cold, non-living, non-heated, not biologically integrated anymore, you know, tissue substance. And so to understand what happens in vivo is such a different experience. And the best we get is fresh cadaver dissection. Until I was able to work with fresh cadavers myself, I didn't appreciate how interconnected and how fine some of these things are, yet how durable they are when put in the right positions. So I really do think it does come down to cadaver availability as well.
Thank
And,
you.
and surgery, for example, if you assist or observe a surgery, you can see that more and more surgeons now are starting to pay attention, because you can see these fascial planes during surgery. And if you use blunt tools to preserve the fascia during surgery, you can have a different surgical approach that preserves the fascia in certain circumstances.
Thank you so much. I am going to combine actually 3 questions from our audience and ask them in one. And I think Monica is also looking at the questions from the audience. One of the questions is about, as we are aging, we are trying to figure out how we can maintain or prevent our connective tissue and fascia from tightening. And there are several questions about different modalities. Is yoga enough? Is stretching enough? And I guess this is a practical question for everyone, that as we age, how can we make sure that our fascia as a system remains healthy? And the question about yoga was that there were discussions back in the day about the health of fascia in yoga classes.
I can start here. I mean, this is such a broad-based kind of interesting way of looking at it. But when you think about fascial slings, not everybody's slings move the same way. And so when you go to a yoga class, you're trying to make someone that may have, say, something like hip anteversion. The hip has a totally different angle of the femur to the acetabulum of the pelvis than someone else's. And yet we are trying to make them move all the same way.
Mm-hmm.
And so I think the challenge from looking at big group classes and things is, if you get someone that's sedentary that doesn't move much and you get them to yoga, they're going to have great gains. But if you have someone that already moves pretty well and they have a back injury because of something that happened, they might not get the same effects out of it. So if you pool a big sample, you might have varying degrees of statistical like relevance from one group to another. So it really comes down to, are we studying all the same people, and what does that look like? Which is the challenge of research, especially when you look at the challenge of research understanding Eastern medicine, right? And the way the mind-body connection of that goes into it all. So I think you can't blanket statement any of this, but whittle it down more to this population versus that population, which is the challenge of it all. I need to know, did this person have a back injury? What's their age? Do they have maybe a fused L5 to S1, meaning their low back only has 4 vertebrae that move and not 5 like the rest of us? And all those things matter, because that'll change the force distribution of the way things move together. So the big take home is, like, we need, I think, trained eyes to understand how people move and then what their limitations are based on their genetics or their structure or the other things that come along with the big package of it. But that's a start.
I agree with all of that. There's another thing too we can teach people to do themselves, is to encourage them to have more self-awareness of how they move. And we get a lot of proprioceptive signals from in deeper tissues. We just sometimes don't pay attention or ignore them. And so if you, for example, you do a specific movement and you're moving in a certain direction and you start feeling some pulling, to pay attention to that, and perhaps, especially if you start feeling a little pain, just backing off and easing into the movement. And a lot of times people just don't pay attention, and then they keep pushing, and then they injure themselves. So the idea is that, stretching is great, but excessive stretching essentially rips, right? So you don't want to injure too much gain too fast. So proprioceptive awareness, paying attention, that's all really important. And a lot of these things like yoga, for example, some, not all, but some yoga instruction emphasizes that.
Thank you. Thank you so much.
So we have one question from the audience. There's been a lot of talk about, what happens with restricted mobility, but we have this question: are there studies being done on fascia with people with Ehlers-Danlos syndrome or with hyperflexibility in general?
Yeah, well, that
Can
was
either of you
actually
comment on that?
the paper that Dr. Jafari was mentioning, that, where, yes, I think the important thing is people who are already hypermobile, their connective tissues is, there's a spectrum of hypermobility going from just hypermobility syndrome all the way to frank Ehlers-Danlos that has other problems such as, lens dislocation, aortic root dissections, things like that. But if we're just talking about simple hypermobility, the people who have already a lot of shear plane motions, sometimes their joints are not very well stabilized during a given movement. And so they have to really, stretching more for these people is maybe not necessarily the best thing. They really have to work on strength and strengthening and making sure that their muscles are able to support the movement. And I think, as Dr. DePrado mentioned, that you have to, I wrote it down because I really liked it, what you said, is that the flexibility is only part of it, right? It's you have to also be flexible during motion, during muscle activated contractions.
With control.
So anyway, I'll let you talk more, but I really like some of the things you said regarding that.
Thank you. Yeah.
A follow-up. Oh, sorry. So this
I'd be
is a
interested to see
follow-up.
what
Yeah,
you
I'm
feel.
sorry. Go, Christopher, because
Yeah,
I was gonna
say, the mobility component is so undervalued. And I think even people that have movement restrictions, there's a saying that you need proximal stability for distal mobility, right? I can't shoot a cannon out of a canoe, right? That we say this type of stuff all the time. Like, you really need to have that strength and stability from the pelvic floor moving all the way out to the distal extremities as stable as possible while you move through gaining range of motion and getting better mobility as you go through yoga or as you go through other kind of movement modalities that will help, I think, improve people's ability to move.
the follow-up question, I think you answered. It was about the role of fascia in fibromyalgia. So people who experience fibromyalgia, what are your thoughts on the connection?
Well, I can say the syndrome of fibromyalgia is still very poorly understood. There's a spectrum, and recently at NIH, we had a workshop on myofascial pain syndrome, which is not exactly the same thing as fibromyalgia, but there's a whole spectrum of people who experience pain and tenderness to palpation, either in localized areas or kind of more generalized all over the body. And when it becomes more generalized and it's accompanied by other sort of neurological symptoms such as problem with sleep and perhaps depression, perhaps other dysfunction in organ systems, then it becomes more of a generalized disorder that is more in the central nervous system kind of domain. Or if it's just one or two areas that have sort of these tender, sort of painful, sort of indurated area, that's more, more like myofascial pain, where you have a localized abnormality in one or a couple of muscles, sometimes kind of related to each other, and pressure can reproduce the pain, but also can cause release of this. And we know very, very little about the pathophysiology of this. And this is one area where we just recently had a workshop about developing better methods to measure the abnormalities of the peripheral tissues in myofascial pain syndrome that could also be helpful in fibromyalgia as well.
Mm-hmm. Thank you. I have a question that has been asked by a few of our audience members, and this is when it would be a good time to start. The question is about injuries such as ITBS injuries. So you're resting, you're taking NSAIDs, you got injections. decompression is not enough. So would this be a good time to resort to what Dr. DePrato presented?
Yeah, I think, one of the big issues is people don't move early enough after an injury. We have a lot of fear around injuries or around surgeries. And if you look at the way we managed rehabilitation protocols 20 years ago, we would, really restrict people's motion after, say, an ACL injury. We would have them in a big cast or like a big brace, and they wouldn't put their foot down for 6 weeks. And now we want them early mobilization, get it moving as soon as possible. And so we try to preventatively kind of go about doing more earlier, and it seems to be a better equation of better outcomes. So I think when you haven't done that and you've had an injury and maybe you took too many NSAIDs, maybe inflammation was shut down so much that it didn't heal the right way, right? Maybe it got glued together so hard that now it doesn't glide the way it was supposed to, when if you didn't take the NSAIDs, maybe it would have just inflamed and then had a local inflammatory response, which repaired it the right way. I think that's one of the big debates and topics, especially in sports medicine, is why are we throwing, Aleve and Advil and all these different NSAIDs at people when inflammation's there evolutionarily for an important reason, right? It's really important for inflammation to take its course, do its thing, and hopefully you're continuing to move so things don't glue so abnormally kind of disorganized, right? And it's not impairing that space that we're talking about. But if it is getting back to, like, say it's 6 months after an injury and you didn't do it the right way, sometimes we need to kickstart that system. And that's where I think that manual medicine comes in. You start to use things like tools, scraping tools, or the cups for negative pressure to create space, improve that gliding, and you're turning over fibroblastic activity. So you're getting the fibroblasts hopefully to lay down new things, because inflammation leads to proliferation and proliferation leads to remodeling. And to get remodeling to happen, you kind of got to stir the system up again, right? To get it to hopefully go the right way. And this time you're going to move better earlier and hopefully that helps that healing process smooth out a little bit.
Thank you.
Yeah.
Thank you. We have other very specific questions that are specific to, they are very patient specific questions. So I'm going to combine them all. And I believe that we've already heard some answers, but I guess the question is when to start the treatment of fascia, which Dr. DePrato just answered. And another question was actually along the same lines, but it was for Dr. Langevin. And I'm not sure if I understand the question. It's about what percentage of force did you say the CT fascia puts on the perimuscular fascia? I believe you mentioned that, but I don't remember the specifics.
What percentage does the actual muscle create internally, or the amount of force? I wouldn't be able to tell you that in newtons or whatever the amount of force, but first of all, it's hard to measure force inside the tissue. What we're much better at is measuring strain. A lot of people confuse stress and strain. Stress is the amount of force per cross-sectional area. That's how you measure stress. And then strain is what we call delta L over delta L over L0, right? It's the change over the initial length. So when in that little video that I was showing you about the sliding of the connective tissue, we recorded as much as 75% strain. That's a lot of movement, wow. Right? This would be 100% strain would be this. If you have two things on top of each other and go all the way out like that, that's 100% strain. So in this particular healthy thoracolumbar fascia, the amount of strain was 75%. So 3/4 of all the way. And then we also tested people who had chronic back pain. And on average, their strain was reduced. They were down to 50%, this much. So how much force does it take to produce that? I wouldn't be able to tell you. But I mean, you can measure applied force, like how much force you deliver, like using a manual, tool, or you might be able to measure the forces applied during your cupping, I imagine. I don't know if people have done that.
Yeah,
but
we look at the millimeters of mercury that we produce with it. And so you can see
pressure.
the millimeters of mercury done with that. But I think the other part of that answer, maybe it can go back to a 2007 study where they looked at myofascial force transmission. And when you pull on tendons attached to a muscle, the fascial forces that are lost can be anywhere from 25 to 30% of fascia taking the forces instead of just the muscle and the tendon. So if you look at things in a linear application, you think all the force is going this way when really it's going all these other directions because of the connections of the connective tissue, right? It's called connective tissue for a good reason.
Yeah. Well,
Now,
thank you.
I wonder if I could just go back to the previous injury repair question, because it occurred to me there's another thing that might be important here with regard to NSAIDs.
Mhm.
So when you look at inflammation, there is a part of the inflammatory response that actually is what we call the resolution phase of inflammation. And this resolution phase is built into the inflammatory response. So essentially inflammation actually turns itself off naturally. That's how you don't, if you cut yourself, you don't have inflammation 2 weeks later. But when you take NSAIDs, you suppress both. You suppress the inflammation, but you also suppress the resolution.
Oh.
And we're starting to understand this, and there's still some debate about this, but I really resonate very much with what Dr. DePrada was talking about in terms of the NSAIDs are not necessarily the panacea in helping heal, especially sports injuries. Yeah.
Thank you. NSAIDs refer to a group of drugs.
Non-steroidal, right, anti-inflammatory.
Exactly. So we're talking about ibuprofen and other non-steroidal drugs.
Things that people take a lot.
Yes.
Especially athletes.
Absolutely.
Yes. We are at the top of the hour, but I have a burning question that was actually sent to me by a couple of people before our seminar. So I would like to ask that. And this is a very general question about looking at fascia as a transportation system, as a connective tissue system that is connecting everything in our body. And the analogy is made to our blood vessels. And we carry blood cells in our blood vessels to carry oxygen and nutrient to various cells and organs. So if we were going to make an analogy and looking at fascia as a system, what would be the currency of this system? What would be an equivalent for a red blood cell or anything that can carry it? And this particular colleague told me that maybe we need to turn into quantum physics to understand what is the currency. So I would like to know what your opinion is.
Well, Dr. Daly had a good answer to that in our previous discussion right before this.
I'd suggest that we just turn to regular physics in this case, because fascia connects the brain to the body through forces. So, as we've been talking about, the connective tissues transmit the loads from the muscles to the bones through all of the connective tissue structures. So it's a network for transmitting the forces. So we probably don't have to go all the way to quantum physics in order to, but I think there's been some really good points about we do have a lot more to understand. And I think that in particular, I'm fascinated about trying to understand the plasticity in the system that is ongoing throughout life and how it adapts to exercise and sedentary behaviors. And I think we really need to focus on understanding that adaptation and that plasticity throughout life and really educating people about that. So that's really important.
Yeah, I would add it's the mind-body connection. Your body has all these tiny little receptors called mechanoreceptors, and they're just feeding so much information to your brain every day, all day. And to understand that there's thresholds that some people can take and some people can't. And so each of those understandings of the different systems additively leads to like decision-making for your brain. And so a lot of it comes back down to that mechanoreceptor and what forces having effect on the nervous system and the body in general.
Thank you. Well, thank you very much for participating in our seminar. It was, I can't believe that we've been here for 1 hour and almost 5 minutes. So I would like to thank you for participating in this seminar. We are hoping to put the recording on our center website. So for our friends and community members who could not participate in this seminar, you can access the recording. And I would also like to thank our program coordinator, Mr. Ryan Wallace. Many of you in the audience and also us have received emails from him and reminders, and I would like to thank him for all his support and effort organizing our event. Thank you so much for participating, and I apologize if we were not able to answer all the questions. Hopefully in future seminars, we will answer them. Thank you.
Thank
Thank
you.
you.